in for evaluation of a mobile lesion on the scalp. So if you've watched enough of these, you recognize there's two types of cysts we predominantly take out. One's called an epidermal cyst or an epidermoid cyst, and the other's a pilar cyst, and this would be a pilar cyst. Now, there shouldn't be many complications with this. The only thing I'd tell residents when you're doing this procedure, if you look at this, we've put anesthesia into it. The problem you get into sometimes that blurs your margins. So when it's a smaller one, the bigger ones are actually easier because you can't be off the plane. The smaller ones, obviously, if we're incising along this line and say the cyst is just a little bit off, you can miss it. So sometimes you'll have to convert to a little bit of an elliptical incision just because you're actually missing the plane. But hopefully we should be on target with this and see how we do with things. The other issue too here is, do we need to cut the hair back? I mean, what I would tell patients, in general you don't, and sometimes you can pin or tape hair back. This patient has small hair, so there's not much to pin back. You could shave it. If you're just getting used to it, it's really going to cause you trouble. I would discuss that obviously with the patient ahead of time, and you can shave it down. You don't really need to. You'll see it gets in your way just a little bit, but not enough that it actually compromises the procedure at all. And that doesn't hurt at all? No pain there? No. And so again, the other teaching point with this is not an infected field at all. So we should have very good anesthesia here. And what I mean by that is, if he described any discomfort whatsoever, we could certainly just add extra anesthesia and it should work. At times when we deal with situations where there's an infection present, then the anesthesia may not work well, and not that we don't try, but then patients just need to be aware sometimes that they may feel a little bit of some discomfort that's there. You still have to address that for sure, but it can be more complicated. In these particular cases where there's no issue whatsoever, then we should have very good anesthesia. So the other note here too is with the scalp, you can develop a lot of bleeding. The scalp is pretty vascular. So don't be discouraged by that. Or I would, again, another teaching point being is you have to think about that ahead of time. So you should certainly make sure that you position the patient in such a fashion that if this is going to be bleeding down, he's bleeding down into something that's protected. I've seen some emerge clips or some young docs who will be doing these sitting up. They don't think about that, and then the patient's bleeding down into their face or something along those lines, and that's obviously not something we want. So here again, the only thing we're trying to do is get to the right plane. So sometimes when you watch this, you can be frustrated with it. I always tell residents just to go slowly with it, because once you get to the right plane, it'll open up, and you just don't want to, if we can here, we don't want to compromise the cyst if we can avoid it. And this will be a little bit harder than with epidermal cysts, because there's not usually as thick a hair follicle presence. You can usually get through it a little bit easier. On the scalp, sometimes you'll be dealing with it's like anything else, just a bigger support structure because the hair follicles are intervening. So if you see here, as I'm spreading this open, you should be able to appreciate that right there. That's the cyst sitting there right there. And that's what you want to be looking for. That's not hurting at all?
No, it's good.
So again, I just tell you, don't be in a rush with it. So what I try and do is, I'll try and use, these are curved Cryleys. You'll see this type of instrument. There's also Kelly's, which looks similar. It's a little bit bigger version of the same thing. This is a blunt instrument. And some people prefer using a sharp instrument. Like, you'll see a lot of dermatologists and plastic surgeons and ER docs and general practitioners who certainly use scissors and use them well, or they'll use a scalpel more. Again, I try and teach to just go slowly with things, and if you can use the blunt instrument, the advantage obviously being is your risk of opening the capsule up is much less, and I think in general if we can do that and not open up the capsule, we'll certainly be content with the fact that we have this completely out when in fact we do. So all I'm trying to do, it may not seem like much, but I'm just breaking down adhesions. So if you've seen any of these I've done before, ultimately what I'm going to try and be doing is keep in mind, so this is a circular structure, so at some point, if I can get the Criley's in, open it up, and then rotate them, as it rotates, I can break down posterior adhesions. And then hopefully this just pops out for us. Either way, if it didn't pop out, so you'll see me do that now, so I'm going to open this up, I'm going to rotate it. So you can see there, so the capsule broke a little bit. So there's just more posterior adhesion here. So when it holds on to it, then unfortunately the capsule breaks down a little bit. So you can just see that's the whole thing there. And that's now that it's collapsed, and this is the whole cyst there. It's wrapped out. Now that it's taken the keratins out of it, doesn't look so large. At least now we know that the whole thing is out. So now, despite the fact that it came out entirely, I just want to make sure I check it a little bit. Make sure that I don't see any type of remnant whatsoever. And I don't, there's nothing there, so now I'll just put in a couple of sutures, and this is the part where you feel complications of not cutting the hair back. Again, not a big issue, but at the end of all this, we'll just have to go back over and make sure that we clear the hair out of the sutures, because as you'll see when I tie these down, we will catch a little bit of hair in it. It's not hard to pull it back out, so you see how this will lay flat, just like that. That's how we want them to lay. And this is another point. I find a lot at times people are quick to try and cauterize tissue, and I don't fault surgeons or physicians who want to do that, but typically, you're going to tie these off with your sutures. So unless it's really bleeding, you really don't have to pressure yourself from that perspective. It will stop. The field can be a little bit more difficult for you to be working with, but not to the point where it compromises anything. The other teaching point I give you too is that when you're doing this as a resident, when I'm pulling through the suture material, I'd leave it a bit long. So this patient's hairline is obviously, he's got a small growth of hair here, so it's not very thick. And what I mean by that, it's not long or anything else. So you won't get your suture material lost in the hair, which can sometimes be a complication. Sometimes when you're doing women, you can lose your suture material. So just, if you're going to have enough to be able to do a number of sutures anyway, just leave it a bit long, and then you won't give yourself that complication. So this should be good with just one more. So again, I'll pull that through and just leave it a little bit long. So I can easily grab this above his hair and pull it down. Go. So we'll just clean that up, and then I'll just use this to sort of dissect it out slowly, and he should be all done. So we're good.